You have been careful about the obvious things. You know salt is something to watch. You have probably reduced it or tried to. You know that soda is not good for you. You may have cut back on that too. You read labels when you remember to. You have made an effort, the kind of sincere, sustained effort that most people make when they understand that what they eat has consequences for their health. And yet there is something in your kitchen right now, something in your refrigerator, something in your pantry, something you almost certainly consumed today and will consume again tomorrow. That is doing something to your kidneys that most physicians do not have time to explain in a standard appointment, that the label does not communicate clearly, and that the food industry has little financial incentive to make easier to understand. It is not the salt shaker. It is not the obvious villain you have already been warned about. It is a category of food additives so ubiquitous in the modern food supply that avoiding it entirely would require a nearly complete restructuring of how most people shop, cook, and eat. It is present in bread and cheese and deli meat and frozen meals and fast food and flavored drinks and dozens of products that carry health claims on their packaging. It is consumed in quantities that have increased dramatically over the past 4 decades as processed food has displaced whole food in Western diets. And its specific mechanism of kidney toxicity is one of the most well-characterized and consistently documented relationships in nephrology, a field that has been raising concerns about this substance for over 2 decades while the general public has heard almost nothing about it. The substance is inorganic phosphate. Specifically, the synthetic phosphate additives used across the processed food industry as preservatives, texture enhancers, moisture-retaining agents, and flavor stabilizers, added to food under names that most people walk past on ingredient labels without recognition, informs that the kidney processes fundamentally differently from the phosphate found naturally in whole foods. I want to explain this distinction carefully because it is the most important thing I will say today, and because getting it wrong leads to conclusions that the science does not support. Phosphorus is an essential mineral. Your body requires it. It is a structural component of every cell membrane in your body, in the form of phospholipids. It is integral to the backbone of DNA and RNA. It is central to ATP, adenosine triphosphate, the molecule through which your cells store and transfer energy. Approximately 85% of your body's total phosphorus is stored in bone mineral, alongside calcium as hydroxyapatite, the crystalline compound that gives bone its structural hardness. You cannot live without phosphorus, and the goal of what I am describing today is not phosphorus avoidance. It is the specific discrimination between phosphorus in its natural form and phosphorus as it is delivered by the food additive industry. Here is where that distinction becomes medically significant. Phosphate in whole foods, in meat, in fish, in eggs, in legumes, in dairy, in nuts and seeds, is bound to proteins and organic molecules. The digestive system must break those bonds to liberate the phosphate for absorption. The efficiency of that liberation is regulated. The gut absorbs approximately 40 to 60% of the phosphate in whole food sources, and the absorption rate is influenced by a hormone-mediated regulatory system that adjusts based on the body's current phosphate status. When phosphate levels in the body are adequate, absorption from whole food sources decreases. The system is not perfect, but it has a regulatory dimension that limits the degree to which dietary phosphate from natural sources can overwhelm the kidney's ability to manage excretion. Inorganic phosphate additives, sodium phosphate, potassium phosphate, phosphoric acid, calcium phosphate, polyphosphates, and the dozens of variants listed on ingredient labels are in free ionic form. They require no enzymatic liberation. They cross the intestinal wall rapidly and completely, with an absorption rate estimated at 80 to 100%, roughly double the absorption efficiency of naturally occurring phosphate from whole food. The regulatory mechanisms that modulate absorption from whole food sources do not apply with the same effectiveness to the rapid, high-concentration phosphate load delivered by additives. The gut absorbs it, the blood receives it, and the kidney must deal with it. That dealing, the renal excretion of excess phosphate, is something the healthy kidney manages reasonably well in young adults with full kidney function. But the kidney's capacity to excrete phosphate depends directly on the glomerular filtration rate, the measure of how much blood the kidneys are filtering per minute. As kidney function declines with age, as the glomerular filtration rate decreases by approximately 1% per year after 40, the kidney's phosphate excretion capacity decreases in exact proportion. The same dietary phosphate load that a 30-year-old kidney handles without difficulty becomes a progressively larger challenge for the kidney at 60, at 65, at 70. This is the core of the problem, and it sets in motion a biological cascade that most people consuming processed food daily are entirely unaware of. When blood phosphate levels rise, even within what standard laboratory reference ranges consider normal. A hormonal response is triggered that has consequences extending far beyond phosphate management. The primary regulatory response to rising phosphate is the release of a hormone called fibroblast growth factor 23, or FGF23, from bone cells. FGF23 signals the kidney to increase phosphate excretion and simultaneously suppresses the activation of vitamin D, reducing the gut's absorption of calcium and triggering secondary responses that include the release of parathyroid hormone. This hormonal cascade, when activated chronically, as it is in anyone consuming high-phosphate processed food daily over months and years, produces a set of consequences that the nephrology literature has documented with increasing clarity over the past 2 decades. Elevated FGF23 is now recognized as one of the most potent independent predictors of cardiovascular mortality in patients with chronic kidney disease. A 2011 study published in the Journal of the American Medical Association found that among patients with chronic kidney disease, each doubling of FGF23 levels was associated with a 75% increased risk of death from cardiovascular causes, independent of other risk factors. FGF23 elevations precede detectable changes in serum phosphate, meaning the hormonal damage is occurring while standard laboratory values still appear normal. By the time blood phosphate rises visibly on a standard metabolic panel, the FGF23-mediated damage has been accumulating for potentially years. Elevated FGF23 directly promotes left ventricular hypertrophy, thickening of the heart muscle, through effects on cardiac cells that are independent of its role in mineral metabolism. It promotes the activation of the renin-angiotensin-aldosterone system, elevating blood pressure. It impairs endothelial function in blood vessels through mechanisms that parallel and compound the endothelial dysfunction driven by aging itself. And critically, it accelerates the decline of kidney function in a self-reinforcing cycle. As kidney function declines, phosphate clearance decreases, blood phosphate and FGF23 rise further, and the elevated FGF23 itself causes additional kidney injury through inflammatory and fibrotic mechanisms within the kidney tissue. The cycle, once established, is difficult to interrupt. A 2012 analysis published in the Clinical Journal of the American Society of Nephrology followed over 10,000 adults without diagnosed kidney disease and found that higher dietary phosphate intake, specifically from processed food sources, was associated with a significantly accelerated rate of kidney function decline over the following 14 years. The relationship was dose-dependent. Higher processed food phosphate intake, faster decline, and the effect was independent of overall protein intake, sodium intake, and caloric intake, meaning it was the phosphate specifically, not simply general dietary pattern, that explained the association. Now I want to show you where this phosphate actually is, because the abstract knowledge that processed food contains phosphate additives is not the same as the concrete, specific understanding of which products are the primary sources in most people's daily diets. And that specific understanding is what changes behavior. The highest concentration of phosphate additives is found in processed meats. Deli meat, ham, turkey, chicken breast, roast beef as sold in supermarket deli counters or prepackaged slices contains phosphate additives as water retention agents and texture stabilizers. A standard 3-ounce serving of processed turkey breast can contain 200 to 300 milligrams of additive phosphate in the high-absorption inorganic form. Bacon, sausage, hot dogs, and packaged meat products are similarly phosphate-loaded. If processed meat appears at breakfast, in a sandwich at lunch, or as a dinner component, phosphate additive exposure from this category alone can reach 600 to 900 milligrams per day, before accounting for any other source. Fast food and frozen prepared meals are the second major source. Chicken nuggets, processed fish products, frozen burritos, ready meals, and most fast food items across all categories are prepared with phosphate additives that serve multiple functions. They tenderize meat, retain moisture, extend shelf life, and improve the appearance and texture of the final product. A single fast food meal, burger, fries, and a cola, can deliver 500 to 700 milligrams of additive phosphate. Processed cheese and cheese products, not natural aged cheese, which contains naturally occurring phosphate, are significant sources. American cheese, cheese spreads, processed cheese slices, and many packaged cheese products contain sodium phosphate or disodium phosphate as emulsifying agents. Natural cheese does not contain these additives, but the distinction is not always obvious on packaging. Cola beverages, regular in diet, contain phosphoric acid, which is both a flavoring agent and a pH adjuster, and which contributes directly to inorganic phosphate load when consumed. The phosphoric acid content of a standard 12-ounce cola provides approximately 60 milligrams of highly bioavailable phosphate per serving, and in individuals consuming multiple colas per day, this becomes a non-negligible contribution to total phosphate exposure. Baked goods made with commercial leavening agents, nearly all commercially produced bread, rolls, biscuits, muffins, pancake mixes, and similar products, contain calcium phosphate or sodium acid pyrophosphate as leavening components. A serving of commercially produced bread can contribute 100 to 150 milligrams of additive phosphate. Flavored instant oatmeal, flavored yogurt, many breakfast cereals, coffee creamers, flavored milk products, protein bars, and a significant proportion of products marketed as healthy, convenient, or high protein contain phosphate additives in various forms. The healthy label and the phosphate additive content are not mutually exclusive, and this is one of the most common sources of confusion for people who believe they are eating carefully. The ingredient label names to recognize are sodium phosphate, disodium phosphate, trisodium phosphate, potassium phosphate, dipotassium phosphate, calcium phosphate, dicalcium phosphate, phosphoric acid, sodium acid pyrophosphate, sodium hexametaphosphate, sodium tripalaphosphate, and tetrasodium pyrophosphate. Any ingredient containing the word phosphate or phosphoric is an inorganic phosphate additive. Learning to recognize these terms on a label is one of the most practical things a person over 60 can do for their kidney health, because it converts the abstract awareness of phosphate risk into a specific, actionable ability to make different choices at the point of purchase. The Food and Drug Administration classifies phosphate additives as generally recognized as safe, GRAS, and has not established a specific limit on their use in the food supply. This classification, which was established decades ago, has been criticized by nephrology researchers who argue that it does not adequately account for the cumulative exposure, and that it does not reflect the distinct bioavailability and metabolic consequences of inorganic versus organic phosphate. The GRAS classification does not mean the nephrology community considers high-processed food phosphate intake safe for adults with reduced kidney function. It means the regulatory framework has not yet caught up with what the clinical research has been showing for 2 decades. The estimated total phosphate intake from a typical Western diet, including both naturally occurring and additive sources, now frequently exceeds 1,500 milligrams per day, and in individuals with high processed food consumption, 2,000 milligrams or more is not uncommon. The National Kidney Foundation's dietary guidelines for phosphate management in chronic kidney disease target 800 to 1,000 milligrams per day total. Most adults with early kidney function decline, who have not yet received a formal diagnosis, because chronic kidney disease is largely asymptomatic until advanced, are consuming 2 to 3 times the phosphate that nephrologists recommend as protective. I want to be direct about what the research says happens to kidney tissue under chronic phosphate excess, because this is where the biological stakes become impossible to dismiss. Elevated circulating phosphate, even within the upper range of what standard labs consider normal, directly activates inflammatory signaling pathways within kidney cells. Tubular cells, the cells lining the renal tubules that perform the fine-tuning of blood filtration, are particularly sensitive to phosphate toxicity. Excess phosphate exposure triggers oxidative stress within tubular cells, activating pro-inflammatory and pro-fibrotic signaling cascades that damage the tubular architecture and initiate the fibrotic scarring that is the histological hallmark of chronic kidney disease progression. This process, tubulointerstitial fibrosis, is the common final pathway of most forms of kidney disease regardless of their initial cause. And phosphate excess in the presence of reduced kidney function accelerates it through mechanisms that are now well characterized at the cellular and molecular level. Phosphate also contributes to vascular calcification, the deposition of calcium phosphate crystals in the walls of blood vessels, through its effects on smooth muscle cells in the vascular media. Elevated phosphate promotes a phenotypic shift in vascular smooth muscle cells from a contractile to an osteogenic, bone-forming state, in which they begin to calcify the surrounding tissue. Vascular calcification stiffens arteries, impairs their ability to buffer the pressure wave of each heartbeat, elevates pulse pressure, and dramatically increases cardiovascular risk. The kidney-heart axis in chronic kidney disease, the bidirectional relationship in which kidney disease accelerates cardiovascular disease and cardiovascular disease further damages kidneys, is substantially mediated by phosphate-driven vascular calcification and FGF23 elevation. This is why chronic kidney disease kills more people from cardiovascular events than from kidney failure itself. The cardiovascular consequences of the hormonal and vascular changes driven by phosphate excess and FGF23 elevation outpace the progression to dialysis requiring kidney failure in the majority of patients with chronic kidney disease. Managing phosphate is not simply about protecting the kidneys. It is about protecting the heart that the kidneys are simultaneously destroying through the hormonal cascade of phosphate excess. Now, I want to address sodium because it belongs in this conversation, even though it is not the primary focus today, because the two work together in ways that amplify each other's damage to kidney tissue. The kidney excretes both phosphate and sodium through overlapping transport systems. High sodium intake increases the work of sodium excretion, creates a hemodynamic environment of elevated blood pressure and increased glomerular filtration pressure, and through the associated renin-angiotensin-aldosterone activation, promotes the same tubulointerstitial injury that phosphate excess drives through its separate pathway. When both sodium and phosphate are elevated simultaneously, as they characteristically are in processed food, which is high in both, the combined renal stress is greater than the sum of its individual components. A 2020 study published in the American Journal of Kidney Diseases found that among adults with early chronic kidney disease, the combination of high sodium and high phosphate intake was associated with a significantly faster rate of kidney function decline than either dietary excess alone. The interaction was synergistic, not simply additive, suggesting that the two insults compound each other through converging mechanisms within kidney tissue. Most processed foods deliver both simultaneously, which is why reducing processed food intake addresses both exposures through a single dietary shift. Let me now move to what is actually actionable, because understanding the mechanism is the foundation, but practical change is the goal. The most effective single dietary shift for reducing inorganic phosphate exposure is also the most straightforward to describe and the most difficult for many people to implement consistently. Replacing processed food with whole food across as much of the diet as possible. Whole food, meat that has not been processed, preserved, or treated with additives, vegetables, fruits, legumes, whole grains, eggs, natural dairy, contains phosphate in the organic, protein-bound form that is absorbed at 40 to 60% efficiency with regulatory modulation. Replacing processed meat with unprocessed meat, cooking a chicken breast rather than buying sliced deli chicken, eliminates the phosphate additive load while retaining the protein value. Replacing commercial bread with bread made from flour, water, yeast, and salt without phosphate leavening agents addresses another significant source. Replacing flavored, processed dairy products with natural yogurt or natural cheese without added phosphates addresses another. This does not require perfection. It requires directional change in the composition of what comes into the kitchen. Reading ingredient labels with awareness of the phosphate additive terms I listed earlier converts the trip to the grocery store from a passive activity into an active filtration of the highest risk products from the shopping cart. Cooking from whole ingredients, even partially, replacing 3 processed food meals per week with whole food-based preparation, meaningfully reduces the additive phosphate load without requiring a complete dietary overhaul that most people cannot sustain. The dose-response relationship between processed food phosphate intake and the biological markers of kidney stress is continuous, meaning that partial reduction produces partial benefit. Perfect is not required, meaningful reduction is. Hydration deserves specific mention in the context of kidney phosphate management. Adequate fluid intake, consistent, well-distributed water consumption throughout the day supports the kidney's phosphate excretion capacity by maintaining adequate urine output and preventing the concentration of phosphate in renal tubular fluid to levels that accelerate tubular cell injury. In older adults whose thirst mechanism is blunted, deliberate, consistent water consumption, not waiting for thirst as the signal, is particularly important. 6 to 8 glasses of water distributed across the day, adjusted for activity level and climate, supports renal phosphate clearance and is among the lowest cost, lowest effort nephroprotective habits available. Certain dietary components have evidence for reducing the absorption of inorganic phosphate from food consumed in the same meal. Calcium from whole food sources, dairy, calcium-set tofu, fortified plant milks, dark leafy greens, can bind phosphate in the gut and reduce its absorption before it enters the bloodstream. This is the mechanism behind the calcium-based phosphate binders used pharmacologically in patients with advanced chronic kidney disease, but at dietary levels, the same principle applies in a milder, food-sourced form. Consuming calcium-rich foods alongside the highest phosphate meals, rather than in isolation, represents a practical harm reduction strategy that requires no additional supplementation. I want to be specific about who needs to take this most seriously and who should have this conversation with a physician as a matter of urgency rather than simply as general health education. Adults with a diagnosed history of chronic kidney disease at any stage should treat phosphate management as a medical priority equivalent to blood pressure management. The evidence that phosphate contributes to kidney disease progression is robust across all stages of CKD, and most nephrology guidelines now include dietary phosphate management as a core component of CKD care. If you have CKD and have not had a specific conversation with your nephrologist or primary care physician about your phosphate intake, that conversation is overdue. Adults with type 2 diabetes, who are at significantly elevated risk for diabetic nephropathy, even in the absence of an established kidney disease diagnosis, should be aware that the kidney damage pathway described today operates in parallel with the glucose-mediated damage pathway of diabetic kidney disease, and the two compound each other. Managing processed food intake is relevant to both mechanisms simultaneously. Adults taking phosphate-containing antacids, many over-the-counter antacid preparations contain phosphate compounds, should discuss this with their physician, as this represents a direct supplemental phosphate load on top of dietary exposure that may be particularly relevant in the context of reduced kidney function. Adults with established cardiovascular disease, coronary artery disease, heart failure, prior stroke, should be aware that the FGF23 and vascular calcification mechanisms described today represent a specific pathway through which phosphate excess continues to elevate cardiovascular risk even in the absence of detectable kidney disease, and that reducing processed food phosphate intake is directly relevant to cardiovascular risk management, not only kidney protection. For adults over 60 without any of these specific diagnoses, the evidence still supports meaningful reduction in processed food phosphate intake as a kidney protective and cardiovascular protective measure. The prevalence of undiagnosed early kidney function decline in this age group, estimated at 30 to 40%, means that a substantial proportion of people watching this today have reduced kidney phosphate excretion capacity without knowing it. A simple blood test, a basic metabolic panel that includes serum creatinine and an estimated glomerular filtration rate, tells you where your kidney function currently stands. If you have not had this checked in the past 12 months, requesting it at your next physician visit is a straightforward step that gives you the most important piece of information for contextualizing everything I've described today. If your eGFR is below 60, the threshold at which chronic kidney disease is defined, the conversation about phosphate intake becomes significantly more urgent. If your eGFR is above 60, but declining year over year from prior measurements, the trajectory matters as much as the absolute number. Knowing where you stand is the foundation of acting with appropriate urgency. Most of the kidney damage I have described today accumulates without symptoms. There is no pain associated with rising FGF23 levels. There is no discomfort from progressive tubulointerstitial fibrosis. The kidneys do not announce their decline. They simply become progressively less capable of the functions that the rest of the body depends on, until the decline is advanced enough that symptoms emerge. And by that point, the window for meaningful prevention has narrowed substantially. The time to act on kidney health is before symptoms appear, not after the diagnosis of stage 3 chronic kidney disease, not after the first hospitalization for a related complication. Now, while the kidneys still have the reserve capacity to benefit from reduced exposure to the substances driving their decline. Reading the ingredient label of everything that comes into your kitchen this week, identifying the products that contain phosphate additives, replacing 2 or 3 of the highest exposure items with whole food alternatives, drinking water consistently and deliberately, having your kidney function checked if you have not recently. These are not dramatic interventions. They do not require pharmaceutical expense, complex protocols, or radical lifestyle upheaval. They require awareness, the specific, accurate awareness of what is in the food that most people consume without reading, and what that food is doing to an organ that has no voice with which to protest until the damage is already done. Your kidneys have been filtering everything you have ever eaten and breathed and consumed across your entire life. They have not complained, they have simply worked. What they need from you, at this point in your life, is the knowledge to protect them from something that has been accumulating in the food supply for 4 decades, and that nobody has taken adequate responsibility for explaining to the people it is most likely to harm. Now you have it. If this changed the way you are going to read a food label the next time you are standing in the grocery store, if there is one specific thing you are going to check for that you were not checking for before, hit the like button right now. It takes 1 second, and it tells this platform that detailed, honest health information for adults over 60 deserves to reach everyone who needs it. Subscribe and turn on the notification bell. Every week, there is one video here built around what the research actually shows, explained with the mechanism, not just the conclusion, because the mechanism is what makes the information stick. Leave me a comment answering this. When you go to your refrigerator or pantry right now and look at the ingredient labels on 5 products, how many of them contain a word with phosphate in it? Do that today, not tomorrow, right now, and write the number in the comments below. I read everything and I respond when I can.